Imagine just going about your normal routine, right? But recently, you started noticing these physical changes in your body that, well, that kind of dictate your daily comfort.
Yeah, the kind of changes that affect how you sit or, how your athletic clothing fits.
Exactly. Or maybe it even impacts your confidence during intimate moments, but you feel like it is a completely taboo subject. You might not even bring it up with your primary care doctor.
Right, because I think a lot of people have internalized this idea that it's either just vanity or just a standard biological decline that you just have to endure silently.
And it leaves you feeling incredibly isolated. But welcome to today's deep dive. We are actually tearing down that wall today.
We definitely are.
Yeah.
Because the broader cultural narrative really hasn't caught up to the medical reality of what's happening at the tissue level here.
So true. Our mission today is to unpack the hard science, the biomechanics, and the clinical advancements behind restoring volume to the labia majora. Specifically, we are looking at the critical differences in how medical professionals approach this using cross-linked hyaluronic acid.
HA fillers, right.
Right, HA fillers, versus autologous fat transfer, which is also known as lipofilling.
And we have a really comprehensive stack of sources to pull from today. We're going to be looking at recent clinical data, including the Esalane study.
We've got advanced plastic surgery texts, gynecological research.
Yeah, we're going to analyze the cellular behavior of PEG cross-linked hydrogels, the regenerative properties of human fat, and, what this actually means for patient outcomes.
But to understand the engineering of these solutions, I feel like we first have to understand the architectural collapse of the problem, right? We're dealing with labia majora atrophy.
Yes.
And lately, there's been this huge surge of attention on this because of the GLP-1 weight loss drugs. People are calling it the Ozempic vulva.
Right, which is quite the term. And, the rapid systemic fat loss we see with those medications certainly accelerates the issue. But the underlying mechanism is actually something most women face eventually anyway.
Just through natural aging.
Exactly, because the tissue architecture in this area is heavily, heavily dependent on estrogen. So when estrogen levels drop,
Which happens during menopause or postpartum or, like we said, extreme weight loss.
right, when that happens, the estrogen receptors in the vulvar tissue basically signal the fibroblasts to downregulate.
So the cells that manufacture your collagen and elastin just, go on strike.
Pretty much. They drastically slow down production. And at the exact same time, the existing fat pads start to deplete.
Oh, wow.
Yeah, so the extracellular matrix basically collapses. You're left with tissue that has lost its structural integrity. It becomes thin, deflated, and it loses its tensile strength.
Which translates into real-world friction for the patient. Because without that biological cushioning, sitting on a hard chair or riding a bike, or even just wearing yoga pants, introduces these mechanical shear forces on the tissue.
Exactly. It chafes, it pulls. It's actively uncomfortable.
So how do clinicians biologically rebuild that cushion? Let's start with the most accessible method we found in the sources, which is hyaluronic acid filler.
Right. So hyaluronic acid is already a fundamental component of your connective tissues. It's a glycosaminoglycan. And its primary biological function is to basically bind to water molecules.
So it's essentially a moisture magnet.
Exactly. It keeps the extracellular matrix hydrated and pressurized.
But wait, if we already have it in our bodies naturally and the body knows how to make it, why do we need to inject a synthetic version? Why doesn't the body just use its own supply to replump the area?
Well, because your body is constantly in a state of turnover. You have these natural enzymes called hyaluronidases that are constantly breaking down native HA.
Oh, I see.
In fact, natural HA has a half-life in the skin of only about 24 to 48 hours. So if a clinician just injected pure native HA into the tissue, your enzymes would dissolve it before the weekend was even over.
Wow, okay. And that brings us to the cross-linking that was heavily mentioned in the clinical studies. The sources highlighted PEG, which is polyethylene glycol hydrogels.
Right, PEG.
How does cross-linking actually stop those enzymes from just destroying the filler immediately?
It is actually a really fascinating bit of chemical engineering. Manufacturers use PEG to create these covalent bonds between the long chains of hyaluronic acid molecules.
Okay, so they're connecting them.
Yeah, imagine taking a bunch of loose strings and tying them together into this complex three-dimensional macromolecular mesh.
Ah, so putting it together like that physically shields the HA backbone.
Exactly. The hyaluronidase enzymes physically cannot access the cleavage sites to break the molecule apart.
So injecting this HA is essentially like putting a super absorbent sponge under the skin, but it's wearing armor, so the enzymes just sort of bounce off.
That's a perfect analogy. And that 3D mesh also dictates how the filler behaves mechanically, because PEG cross-linked gels are highly cohesive.
Which you would need in a dynamic area, right?
Absolutely. The labia majora undergoes constant movement, stretching, compression. You need a filler that moves seamlessly with the tissue without fracturing or migrating to a different area.
Okay, so let's talk about how this armored gel actually gets into the tissue, because I have to say, the clinical technique detailed in the sources gave me pause.
Oh, the cannula.
Yes. The procedure takes about 30 to 45 minutes in office. They use local anesthesia, and then they introduce the filler using an 18-gauge blunt tip cannula.
Right.
Wait, an 18-gauge instrument is not small, and we are talking about injecting things into an incredibly vascular, highly sensitive region of the body down there. Are we risking nerve damage or numbing?
Very common concern. But anatomy and instrument design are the two major safeguards here. First, while the vulvar region as a whole is highly sensitive, the vast majority of those sensory nerves are actually concentrated in the clitoris and the labia minora.
Oh, okay.
Yeah, the labia majora, which are the outer structures we are targeting here, have a significantly lower density of nerve endings,
But I mean, there are still neurovascular bundles in there, right? You could still hit something.
which is exactly where the blunt tip cannula comes in. So a traditional hypodermic needle has a beveled, razor-sharp edge. If it encounters a blood vessel or a nerve, it slices right through it.
Ouch. Yeah.
Right. But a blunt cannula has a rounded, completely closed tip. The extrusion port is actually on the side of the instrument.
Oh, I see.
So when a clinician advances a blunt cannula through that superficial subcutaneous layer, it doesn't cut anything. It glides along the fascial planes.
Oh, wow. So if it meets a blood vessel or a nerve fiber,
The rounded tip just gently nudges it out of the way.
so it's basically threading the needle, so to speak, through the path of least resistance in the fat layer, leaving the wiring completely intact.
Exactly. Sensation is perfectly preserved. And then they use a slow, linear retrograde technique to actually build the structural support.
Right. I wanted to ask about that. What does retrograde mean in this context?
It means the clinician advances the cannula to the farthest point of the treatment area first. Then they apply steady pressure to the syringe plunger while simultaneously and very slowly pulling the cannula backward out of the tissue.
Wait, why pull backward? Why not just inject a targeted bolus of filler right where they need the most volume?
Because if you inject a large bolus all at once, you create a localized, palpable mass.
Like a marble under the skin.
Exactly, like a marble, by laying down filler in slow retrograde threads, and they often fan them out in multiple directions. The clinician is weaving these microstruts of support.
Ah, so they are building a scaffolding that integrates smoothly with the surrounding fat layer.
Exactly, and that structural weaving clearly works. If you look at the ESALANE study data, which was a multi-center trial, evaluating this exact application.
Right. At week 12, I think it said 87.5% of patients were rated as improved on the aesthetic scale.
Yes. Plus, it has an ultimate safety net. If there's a vascular complication or, if the patient just hates the result, it's reversible. The clinician can flood the area with synthetic hyaluronidase enzymes and dissolve the mesh almost immediately.
That's a huge benefit. But there's a catch, right?
Always a catch.
The enzymes eventually win. The body always wins eventually.
Yeah, it does. Even the PEG cross-linking degrades over time. You are looking at a duration of about 6 to 12 months before the volume noticeably diminishes, so it requires maintenance treatments.
Right. So HA is kind of like a temporary rental solution for volume. But what if you want to buy your results permanently?
Then you are looking at autologous fat transfer.
Also known as lipofilling. Which brings us to the surgical realm. This completely shifts the biological approach, doesn't it?
Completely. Instead of injecting a synthetic hydrogel to mimic tissue, you are transplanting living tissue from one part of your body to another.
So it's a two-step process. Step one is the harvest.
Right, the surgeon uses very gentle liposuction techniques to extract fat from a donor site, which is typically the abdomen, flanks, or inner thighs.
But the sources emphasize that the extraction and purification process has to be incredibly meticulous. Like, they can't just take the fat from the abdomen and immediately inject it into the labia, right? They have to put it through a centrifuge or wash it.
Yes, they do.
What exactly are they washing out?
Well, when you perform liposuction, you aren't just extracting fat cells. You are pulling out tumescent fluid, free lipids from ruptured fat cells, and blood.
Oh, yuck.
And free lipids and blood are highly inflammatory. If you just inject that inflammatory cocktail into the labia, the body will trigger a massive macrophage response to clean up all that cellular debris.
Which I assume is bad for the new fat.
Very bad. It creates free radical damage
Yeah.
and basically kills the healthy fat cells you just spent time transferring.
So you have to isolate only the robust, viable adipocytes.
Yes. And something else incredibly valuable that comes with them. The clinical texts we looked at spent a lot of time on something called the trophic effect.
Yes. I found this part of the research so fascinating. The fat isn't just acting as a passive space filler.
Not at all.
It actually changes the biology of the surrounding tissue, right?
It genuinely rejuvenates it. Adipose tissue is one of the richest sources of stem cells in the adult human body. Specifically, they are found in what's called the stromal vascular fraction, or the SVF.
Okay.
So when a surgeon purifies and transfers this fat, they're also transplanting mesenchymal stem cells and endothelial progenitor cells right into that atrophied labia.
So if HA is like putting a sponge under the skin, fat grafting is more like planting a garden. You aren't just bringing the bricks to rebuild the house, you're bringing the construction workers.
That is exactly right. These stem cells secrete vascular endothelial growth factor,
Yeah.
and that triggers angiogenesis, which is the sprouting of new capillary blood vessels.
Wow.
So the transplanted tissue basically forces the local environment to build an entirely new microvascular network. This improves local blood flow. It stimulates those dormant fibroblasts to start producing collagen again.
So it actually restores elasticity to the overlying skin from the inside out.
Yes. It's essentially a cellular reboot of the tissue.
But, I mean, the mechanics of getting that fat to actually survive the transplant seem incredibly precarious. You are transplanting living cells that require oxygen and nutrients, but they don't have a blood supply yet because they're new.
Right.
So how do they survive until that new vascular network is built?
Honestly, many of them don't. That is the critical challenge of lipofilling. In the first 48 hours, those transplanted fat cells survive purely through what's called plasmatic imbibition.
Plasmatic what?
Imbibition. They basically just soak up whatever ambient nutrients and oxygen are diffusing through the surrounding tissue fluid.
Oh, I see. Which means if a fat cell is buried right in the center of a giant blob of injected fat, it's going to suffocate before the new capillaries can even reach it.
Exactly. This is known as ischemia. The cells in the center of the graft die from lack of oxygen. So to combat this, the surgeon cannot inject large volumes at once. They have to inject the fat in microscopic droplets.
So they have to meticulously layer it so every single transplanted fat cell is within like a millimeter of the host's native blood supply.
Yes. But even with flawless technique, the clinical literature states that anywhere from 30% to 50% of the transferred fat will undergo apoptosis.
Cell death.
Right, it'll just die and be naturally reabsorbed by the body within the first few months.
So the surgeon has to perform this delicate mathematical balancing act, right? They have to slightly overcorrect the volume during the surgery, anticipating that maybe 40% of it is going to vanish.
Yep. But if they overcorrect too aggressively to guarantee the volume, they risk causing that ischemia we just talked about.
And if large clusters of fat cells die, you don't just lose volume, you get fat necrosis, right?
Yes. The body's immune system attacks the dead cells, and that leads to fibrosis and calcification. The patient ends up with firm, palpable lumps under the skin.
Oh, that sounds awful. And because reabsorption rates can vary between the left and right labium, a patient might also end up with noticeable asymmetry.
Which means they might have to go back into the operating room for a secondary touch-up session to balance things out.
And the recovery protocol for this is pretty intense, too. It's a real surgical procedure. The sources state patients must avoid sexual intercourse, horseback riding, cycling, basically anything with friction for 4 to 6 weeks.
Yeah, downtime is very real. We just discussed how fragile those newly forming capillary networks are.
Yeah.
If a patient sits on a bicycle seat 3 weeks after surgery, the mechanical compression just clamps down on those tiny new blood vessels.
You cut off the blood supply to the graft and the fat cells die.
Exactly. So it requires a significant lifestyle pause. But the trade-off for navigating that reabsorption math and the strict recovery is permanence.
Right. The 50% to 70% of the fat that does successfully integrate stays there permanently.
It acts like normal fat. It lasts for years and years, fluctuating only if the patient's overall systemic body weight changes.
Okay, so we've compared the intense bioengineering of the gel versus the fat. But we really need to contextualize what this actually means for the patient's daily life. Like, why go through either of these procedures?
The psychological and functional data here is actually profound.
The research notes that roughly 40% of women experience these intimate tissue changes as they age. And treating this isn't just vanity. It triggers what researchers label an upward spiral.
Yeah, they track this using genital perception scores. When a patient undergoes volume restoration, their perception of their own anatomy improves dramatically. And this reduction in body image distress directly correlates with heightened sexual satisfaction.
Right, because when the psychological distraction of self-consciousness is removed, the patient can actually just be present.
Exactly. But the data goes beyond just feeling better about how things look. The Female Sexual Function Index, or the FSFI scores, show measurable physical improvements.
Right, both HA and fat transfer result in significantly higher arousal and orgasm scores. But wait, if we established earlier that we are specifically injecting filler into the subcutaneous fat layer and actively avoiding the nerves, how on earth is a volume filler increasing physiological arousal and orgasm?
By eliminating the neurological competition.
Okay, explain that.
When labia majora tissue is deflated, it offers zero mechanical cushioning. During intercourse, this leads directly to dyspareunia, which is pain caused by skin-on-skin friction and shear forces.
So the brain is receiving these intense pain signals.
Right, nociceptive signals.
Yeah.
And pain pathways in the central nervous system will always override arousal pathways. It's a basic evolutionary survival mechanism.
Oh, wow. That makes so much sense.
Yeah. So by restoring the physical volume, the HA or the fat graft acts as a mechanical shock absorber. It disperses the friction.
Furthermore, both the HA gel and the stem cells in the fat graft drastically improve mucosal hydration, which combats the severe vaginal dryness that often accompanies estrogen depletion.
Precisely. You decrease the mechanical friction, you restore the local hydration, and you eliminate the pain signaling. Once the pain pathways fall silent, the arousal signals from the nerves that are there can finally reach the brain uninhibited.
The tissue is just allowed to function optimally.
Exactly.
That is fascinating. So, looking at the totality of the clinical data, how does someone evaluate which path to take?
Well, it really requires a frank assessment of a patient's anatomy, their risk tolerance, and their lifestyle constraints.
So if you want a 45-minute lunchtime fix with instant results, minimal downtime, and you don't mind coming back for annual maintenance, cross-linked hyaluronic acid is your choice.
Right. But on the flip side, if you want a definitive permanent tissue integration, if you want those regenerative stem cell benefits, and you don't mind a surgical recovery,
And the risk of asymmetry or touch-ups?
yes, then autologous fat transfer wins. Both are highly effective when performed by board-certified specialists who really understand the complex vascular anatomy down there.
What makes this entire field of research so interesting to me isn't just the aesthetic shift. It's the fact that medical science is finally validating and treating these functional, quality of life issues that used to just be dismissed.
Oh, absolutely. And the clinical techniques are evolving so rapidly to meet that demand.
Which actually brings up one final incredible frontier mentioned in the latest research. We've outlined the choice for the listener, right? The temporary reliable matrix of HA versus the permanent cellular regeneration of fat transfer.
Right.
But the research is pointing toward a future where patients might not have to choose at all. Clinicians are developing hybrid fillers.
This is exactly where tissue engineering is heading. They are mixing hyaluronic acid with a biostimulator called calcium hydroxylapatite, or SAA.
How does mixing those two change the biological response?
Well, the HA component does what we already discussed. It provides that immediate hydrating volume, instantly addressing the chafing and the pain. But the SAA consists of these microscopic smooth spheres suspended inside that gel.
So as the HA sponge inevitably begins to degrade over those first few months, those microscopic spheres are just left behind in the tissue.
Exactly. And your body's fibroblasts, those collagen-producing cells that went dormant, they recognize those Ka spheres as a structural scaffold.
Oh, wow.
Yeah, they attach to the spheres and actively begin synthesizing new type I and type 3 collagen all around them.
Wait, really? So the gel literally tricks your body into building its own permanent biological support matrix to replace the filler as it dissolves.
It does.
Yeah.
It essentially bridges the gap between a temporary lunchtime fix and a permanent structural change, and it does it all without requiring a surgical liposuction harvest.
That is wild. Could the future of intimate wellness and tissue restoration rely purely on engineering our own cells to rebuild the architecture from the inside out?
It's a remarkable trajectory for medical science, for sure.
It really is. Understanding these medical advances just empowers you to make informed decisions about your own body. Thank you so much for joining us on this deep dive. Keep questioning the consensus, keep exploring the science of human biology, and we will see you next time.